Okay, so some of you guys have not been able to open the audio that I had posted with the acid base, so I'm going to go through this again and kind of go through some of the important stuff for you guys as you're learning acid base. Anyway, excuse me. So we're going to start with an overview. So the thing that you want to always remember is these values. So your pH 7.35. Your PaO2 is going to be greater than 90 in a norm. This is normal values. Your bicarb, which is your HCO3, is 22 to 26. And the thing that you want to keep note of there is, remember, bicarb is your metabolic buffer. So when I say buffer, it basically will bring acidity down. If you think of Tums, when you take Tums, that's a buffer. When you have acid reflux, you take Tums and it decreases the acid. So bicarb is what your kidneys are going to secrete so that you can counteract the acidity in your body. Or they're going to hold it in if your patient's too alkalotic so that you're, bringing the acidity back up. Your PaCO2, your carbon dioxide, is normally going to be 35 to 45. The thing you want to remember with CO2 is it's your respiratory acid. So when we're looking to determine whether something is acidotic or alkalotic, the first thing that we're going to do is look at our pH. If it's below 7.35, it's an acid. If it's greater than 7.45, it's alkalotic. The next thing that you're going to do is then look at your bicarb. Is your bicarb below 22 or is it greater than 26? Is it normal? Then you're going to go to your PaCO2 and you're going to say, is it normal? Is it low? Is it high? We already said that bicarb is our buffer, so it's alkalytic when it's high, right? So if we have a patient who has a pH that shows that they're in alkalosis and their bicarb is greater than 26, we know that they're in metabolic alkalosis because both of them match. If we have a patient who has a pH of less than 7.35 and a PaCO2 that's greater than 45, again, that shows acidosis and it would be respiratory. So next slide is a really good slide for really showing you. I'm trying to move this thing out of the way here. I don't think I can do it when I'm in the screen. Anyway, this slide is a great one to show you the findings of acidosis and alkalosis in both the respiratory and the metabolic disorders. So with our initial findings with respiratory acidosis, remember our pH is going to be down because we are acidotic. And we said that the CO2 is a respiratory acid, so it's going to be elevated. Sometimes you'll see the bicarb a little bit elevated because it's starting to kick in and give you a little bit of buffer, but normally it's normal. I'm not going to try to trick you on these questions. If it's an uncompensated patient, I'm going to leave it where it's pretty clear. Your respiratory alkalosis, remember your pH is going to be greater than 7.45. Your PaCO2 is going to be down because obviously it's the opposite of our buffer. Our metabolic acidosis, we're going to have a low pH, and again, we're looking at our bicarb for that, and low bicarb would signal the acidosis. Then for metabolic alkalosis, remember our pH is going to be greater than 7.45, and our bicarb is going to be elevated because we have alkalosis. Now, if you look at the arrows in here, and really the ones that you want to look at for respiratory is your CO2 and your pH, and for alkalosis, for metabolic, you want to look at your bicarb and your pH. So if we're looking at it respiratory in nature, our pH and our CO2 should match up in a specific way, and in metabolic, our bicarb and our pH will match up in a specific way. What you'll see here for respiratory is that our CO2 and our pH arrows will go in opposite directions. So I'm going to introduce you to a little acronym next, and that's ROME. Respiratory is opposite and metabolic is equal. So if we go back to this here, you can see what I'm talking about. Respiratory is opposite. When we have a patient with a pH that's low and they have an acidosis, our PaCO2 is going to be elevated because that is a respiratory acid. When it's acidic, you have extra CO2. If we have respiratory alkalosis, our pH is going to be elevated, showing that it's an alkalosis, and that the PaCO2 is going to be down because we don't have as much of that respiratory acid. So I hope that makes sense to you guys. Your metabolic disorders, again, you're looking at your pH and your bicarb. And remember, if our bicarb is our buffer, when we have an alkalosis that's a metabolic alkalosis, our pH is going to be elevated. I'm skipping to the bottom one. And our bicarb is elevated because it's our buffer. Our bicarb is our buffer. So those two will match up. So those arrows are going to be equal. So if you get used to looking at the arrows and draw your up and down arrows, you'll be able to say, okay, what's my pH? Is it acidosis or is it alkalosis? And then go and look at your bicarb and your CO2 and which one makes sense. If you have a patient who has an acidosis and your bicarb is elevated, you know that it's not metabolic, because an elevated bicarb would be alkalosis. So that just tells you that the patient's starting to compensate. So again, respiratory is opposite and metabolic is equal, meaning your arrows go in the same direction. So if you, again, remember your CO2 is your acid, and it's, your lungs are kicking in, and your bicarb is your base, which means that your kidneys are kicking in. So when we're in one of the disorders, the other system is going to jump in and try to compensate and equal out the the body's acid-base balance. So our steps, again, that we need to look at to determine, we're going to look at the pH. Is a pH below 7.35, above 7.35, or is it normal? If it's below 7.35, it's an acid. If it's greater than 7.45, it's alkalotic. Then we look at our CO2. Is it normal? Is it acidotic, or is it alkalotic? And remember, CO2 is our respiratory acid. So if CO2 is elevated, it's acidotic. If CO2 is low, it's alkalotic. If we then look at our bicarb, is our bicarb normal? Is it acidotic, or is it alkalotic? So if bicarb is our buffer, if it's elevated, it's alkalotic, and if it's low, it's acidotic. Then you're going to match your CO2 or your bicarb with the pH. So what you want to say is, if I have a pH that's acidosis, so my pH is less than 7.35, do I have an elevated CO2 or do I have a low bicarb? And then you'll know, if you have an elevated CO2, it's respiratory. If you have a low bicarb, it's metabolic. Then you look at your CO2 or your bicarb. Is it in the opposite direction? That's going to tell us if the patient is beginning to compensate or not. And we'll get into that a little bit more in a few minutes. And then we're also going to look at our PaO2 and is our SAT normal. These are some really good videos that'll help you when you're going through and interpreting. I usually do show these in class to kind of help you guys, hopefully to, have another way of learning it. Sometimes one way works better for you than others, so by all means look at them, and if one of them is kind of clicking for you, use it. So when we look at our patients with metabolic acidosis, okay, so we're going to look at metabolic acidosis. So what you want to look at is it's on page 268 in your textbook. So your metabolic acidosis is going to be, again, we look at the pH first, and your pH is going to be low. Remember, that's acidosis. And with this, the bicarb is also going to be low. Remember, metabolic is equal. So respiratory is opposite, metabolic is equal. So your pH and your bicarb are going to be in the same direction. They're both going to be low. Your CO2 might be a little bit normal. It also may be low if the body is starting to compensate, and we'll start looking at that after. But just know that your pH is going to be low, and your bicarb is also going to be low in these situations. So things that you want to look at for your pathophysiology, what's going to make this happen If you think about it, it's basically causing an acidosis. This would be when you have patients sometimes with diarrhea, a lot of the lower GI issues, if they have any type of intestinal fistulas or issues, a urostomy, sometimes they'll have this. Patients on diuretics are at risk for this. Patients with early renal problems, so if you start to notice that they have an elevated BUN and creatinine and a low clearance, sometimes you'll see this with these patients where they'll start to go into a metabolic acidosis. You tend to see this with patients who are in DKA with diabetes. So you can see this with a lot of different patients. Another patient population that you tend to see metabolic acidosis, and you have to watch it closely, and is patients that are getting parenteral or hyperalimentary nutrition, or patients with poisonings. I've actually seen it a lot of times with different types of poisonings. There's many different poisonings. So if you have a patient that's had an overdose or an accidental poisoning, you also want to be monitoring for metabolic acidosis in these patients. Some of the signs and symptoms that you're going to see with this, your book talks about they could have the headache, confusion, drowsiness, their respiratory rate and depth are going to increase, nausea, vomiting. And the thing that's interesting is that with diarrhea, you tend to have the respiratory acidosis, and with vomiting, you end up getting, the metabolic acidosis. And with so diarrhea, you get the metabolic acidosis. With vomiting, you tend to get metabolic alkalosis. So vomiting is actually your body's way of saying, like, let's get rid of some of this acid. I'll tell you my trick with remembering this. It's terrible, and if you feel offended by any bad words, and please plug your ears. I had an instructor once that told me that if you remembered metabolic acidosis, it was acid ass. So you lose, you'll get the metabolic acidosis when you have diarrhea, and then it's the opposite with vomiting. That's where you get your alkalosis. So that's the way I always remembered it, is acid ass. So sorry if I offended you, but that is a way that you won't forget it. And if you're sitting on the test looking at it and that becomes a question, you definitely will know which one to pick. So other things, these patients can end up with, decrease in their blood pressure. They can get that cold, clammy skin, dysrhythmias, and they can eventually go into shock. So it's very, very, very important to be assessing this. Another patient population that your book talks about that is also very important is your patients with chronic renal failure, because they can also end up with a chronic metabolic acidosis. So it's something that has to be monitored for. Other things, obviously, you want to watch and make sure if you start to notice any progression to a state of coma, it needs to be watched very closely, especially in patients with overdoses. A smell of, smelling their breath, sometimes you can get, especially with your ketoacidosis, a smell that would signify like that you need to be looking into this. Look for any signs of heart failure in patients who have like a lactic acidosis, if you're noticing the acidosis. So monitoring their labs, checking their cardiac rhythm. These patients are usually going to end up on a cardiac telemetry unit being monitored. You also, obviously, for signs of heart failure, you'd be looking at their B-natriuretic peptide to see if you notice that get elevated. You'll often see these patients have the Kussmaul's respirations. So it's a slow rhythmic breathing that increases the tidal volume. Sometimes in kids, sometimes you'll have children with chronic renal problems with acidosis too. They would have growth issues. So a lot of, generally different types of things. Other areas that you want to make sure you're looking at is their labs. So I mentioned to you that you're looking at, the labs for complications. But another thing that you see a lot of times with these patients is that they end up with hyperkalemia. So their potassium levels are pretty high. So again, we want to watch that and try to correct that. So very closely monitoring your serum potassium levels in these patients is super important. Treatment for patients with metabolic acidosis. They're going to be given IV fluids. A lot of times we're going to give them bicarb and sodium chloride IV to try to combat the acidosis. And if necessary, sometimes they'll do emergent hemodialysis to try to get the blood back to a normal state out of the acidosis. Usually with these patients, you'll obviously end up with critical care, their primary care, emergency physicians, and sometimes nephrology gets involved in their care as well. But again, in emergent situations, hemodialysis, but normally the body will be trying to compensate itself. So if you think of with the metabolic acidosis, how are we going to get that acid out? We're going to be trying to get rid of the CO2, so they'll start trying to blow it off, and then we'll be giving them the bicarb IV. Okay, so with our metabolic alkalosis, our pH is going to be greater than 7.45, so we know it's alkalotic. And then our bicarb is going to be greater than 26. They're going to both be in the same direction, elevated. With the pathophysiology for this, the three things usually causing this are going to be use of diuretics, vomiting, and gastric suction. Those are the three most common things that you'll hear about for this. Treating the cause is one of the most important things that you can do. So if a patient is noted to have metabolic alkalosis, it's figuring out what's happening and how do you treat it. So whether you put them on an antiemetic, you stop the gastric suction, or you change the diuretic therapy. Usually with the diuretic therapy, it's the loss of the potassium. So sometimes they'll put them on a potassium-sparing diuretic instead of like a loop diuretic. Really just depends on what the cause of the metabolic alkalosis is. Clinical manifestations, these patients, like I said, will end up with hypokalemia. So they'll have a low potassium level. They also will have the decrease in the calcium, so they'll have the tingling in the fingers and toes. They'll get dizzy. Sometimes they'll have that hypertonic muscles. They'll complain of pain. Serum calcium levels, we just mentioned are what you want to be looking at. It's going to be down. Then you will often see the patients having issues with respiratory depression. They'll sometimes have a cardiac dysrhythmia. So you want to be looking at their EKG and see, do they have an atrial tachycardia? Again, the trick with this is to treat the underlying cause. So whatever is making this occur is what you want to have reversed. Other things with this that are important, the patient's treatment is another thing, that you want to also look at with this. So what else is important? Treating the cause, figuring out what it is. With these patients, usually they'll just give them normal saline with potassium to correct the potassium loss. Rarely, if they're not able to find the cause and treat it, they will start patients on the carbonic anhydrase inhibitors. The drug that you see most commonly used for that is the acetazolamide. It's ACETAZOLAMIDE. Other times you'll see them sometimes on the H2 receptor antagonist. Your book talks about Tagamet, which is cimetidine. They're just trying to, treat the alkalosis and get the patient more regulated. So with our respiratory acidosis, again, our respiratory is opposite. We're looking at our CO2, which is our respiratory acid, and we're looking at our pH. Our pH is going to be low, showing that the patient's acidotic, and we're going to have a buildup of the CO2, which is going to be elevated, which is our respiratory acid. Excuse me. So for these patients, we're going to see this occurring it's going to be your patients who have acute respiratory issues where they're not able to blow off the CO2. So they aren't going to be breathing adequately, whether their volume's not sufficient or the rate is not sufficient. They're holding on to that CO2. So it could be patients, it talks in your book about pulmonary edema, aspiration, patients with a pneumothorax or pneumonia, anything that's causing them to have difficulty breathing or not breathing enough. Patients with sleep apnea, too much sedation for, a patient who is either given sedatives for a procedure, surgery. It can even be caused by inadequate ventilator settings, which is why when we put a patient on mechanical ventilation, we will go and repeat ABGs, the arterial blood gases, which is where we're going to get our pH, our CO2, our bicarb. We're looking at that to see, is the patient being adequately ventilated? And if not, that's why the changes are made to the ventilator. Patients who have impaired musculoskeletal issues, so patients with MS, myasthenia gravis, Guillain-Barré, any of those types of things, you can also see patients end up with a respiratory acidosis. So you want to be very, very careful and know that these patients are at an increased risk and that you're probably going to have to monitor for this. These patients often will seem somewhat confused. So an alteration or change in mental status is an early sign that you need to be looking at this. They will often have an increase in their respiratory rate because they're trying to compensate. You're also going to see, so we said confusion, the change in the level of consciousness. Other signs and symptoms that sometimes you'll have patients report when they have respiratory acidosis. Blurred vision, if you have someone that's saying they have blurred vision. Headache, anxiety is the other thing. They get very, very anxious and restlessness. In the initial stages of respiratory acidosis, I know I mentioned that you can see them start to increase the respiratory rate. A lot of times when you're diagnosing it, they have a lower respiratory rate or they're not putting out as much volume. When you start to see the respirations increase, their body is trying to start to compensate at that point usually. Other things that you want to look at is monitoring their potassium levels because they could end up with a hyperkalemia with the respiratory acidosis. Another important thing to look at is the patients who have chronic respiratory acidosis. That's going to be your COPD, emphysema patients who are going to always kind of be at that borderline. They're going to have an elevated CO2, and that's because of the pathophysiology of their disease process. So those patients, may always have that, but you want to be looking at, is it getting worse? So with patients with COPD, you want to know what their baseline is. And you also don't want to give them too much oxygen. And you'll learn more about that when you have your respiratory lectures, but you want to be very careful when you're administering not to over-administer oxygen to these patients. Treatment for respiratory acidosis is, pretty much trying to treat, you're going to treat the cause, figure out what's causing it, try to reverse it. Sometimes you'll need to give them a bronchodilator if there's some kind of a airway obstruction issue. Sometimes we'll give them CPAP or BiPAP to try to open up the airways until they can resolve whatever the issue is. Other times we're going to have to put the patients on mechanical ventilation, or if they're on mechanical ventilation, we'll need to change that to make sure that it is adequately adequately ventilating them. Other things with these patients, you might see, that you have very close watch on pulmonary hygiene. So your patients who are on mechanical ventilation, you want to make sure that they don't have something called a mucus plug. So sometimes a mucolytic agent will be implemented if they have a lot of congestion or mucus in the airways. Want to make sure that they're hydrated to keep the mucous membranes moist and also to thin out the secretions. Sometimes they'll give them supplemental oxygen, but again, I mentioned you want to be very, very, very careful with your COPD patients not to give them too much oxygen because you can then alter their drive to breathe. And we did mention the mechanical ventilation. Other thing is making sure that the patient is in an adequate position to be able to expand and breathe adequately. So that'll be your semi-Fowler's position. So sit them up so that they're able to breathe, but don't have them in a 90-degree angle, because if you were to sit, completely at a 90-degree angle and try to really get a good deep breath, you'll see it's not always very easy. So make sure that they are in a position where they're able to breathe comfortably. Okay, so for our patients with respiratory alkalosis, this is pretty much always caused by excessive blowing off of CO2, which is your hyperventilation. This could be someone who's in a lot of pain. Maybe we don't have enough pain control, not enough sedation, or someone who's breathing too much over a ventilator. So ventilator settings can cause this. In patients who have hyperventilation, maybe it's anxiety, stress. These are the patients that you have them rebreathe. So you might give them a paper bag during an acute episode and have them rebreathe their own air to help get them to breathe back in their CO2. Because remember, their CO2 is that respiratory acid. These patients are going to have the pH that's elevated and a CO2 that is low. So their respiratory acid is low, but their pH is high. So they're in an alkalotic state and they're blowing off too much of that CO2. So we want to get that CO2 back, which is why we're having them rebreathe it. If the patient is on a ventilator, we're just going to alter their ventilator settings and make sure that we, get their CO2 back up. With these patients, you're often going to have them tell you that they're very lightheaded. Sometimes they'll have numbness and tingling. They can end up with like a tachycardia or dysrhythmia. So you want to be very, very careful with that and treat it as a medical emergency. You don't want to, you'll see a lot of times you're just hyperventilating. So you really want to reassure the patient, stay with them, let them know they're going to be okay, but, just try to keep them, their stress levels down. In treating your patient with respiratory alkalosis, basically you've got to figure out what the cause is, reduce their anxiety, and correct the CO2 imbalance by making sure that they're not blowing off as much of the CO2. So it's changing your ventilator settings and having them rebreathe their own CO2. Your book talks about compensation, but it doesn't get into partially compensated versus compensated, and that's a really important thing to look at. When you have a patient who has partial compensation, the pH, the CO2, and the bicarb are all abnormal. So if your pH is abnormal and your CO2 and your bicarb are also abnormal, the patient is partially compensating. And what that means, if you look on page 271 in your textbook, when you have a patient with different types of acidosis or alkalosis, something is going to be kicking in on the other side. So if you have a respiratory acidosis, your body starts to compensate by increasing the renal acid excretion, and it will also increase your bicarb in the body. When you have a patient with respiratory alkalosis, your body is going to decrease the renal acid excretion, and it's going to also decrease the serum bicarb. So it's going to stop your body from releasing it. When you have metabolic alkalosis, metabolic acidosis, your body's going to have hyperventilation that's occurring. It's going to do that to blow off and decrease your PaCO2. Your metabolic alkalosis, you're going to have hypoventilation. So the body's going to compensate by slowing down the respiratory rate so that the body holds on to the CO2. So it's important to understand that. But when you're looking at your ABGs, again, you're going to first look at your pH. You're going to look at this one for your CO2 and your bicarb. So remember, with your respiratory, it's opposite. With your metabolic, it's equal. In this case, your patient has a pH that is low, so it's an acidosis, and your CO2 is elevated. So those two match. We know that it's a respiratory acidosis, but again, look at your bicarb. Your bicarb is also elevated, but your bicarb, if it was a metabolic acidosis, and the way you know it's not a metabolic acidosis is if it was a metabolic acidosis, our bicarb would be low, not high, because remember, with metabolic, they're going to be equal. Your pH and your bicarb should be going in the same direction because your bicarb is your buffer. So if you have an increase of your buffer and you have a patient with acidosis, you know that your kidneys are kicking in. Your bicarb is being excreted to try to bring your pH back up and get the patient out of acidosis. So this would be a partially compensated, the top one, partially compensated respiratory acidosis. For your compensated patients, your pH is going to be normal. So when you look at this, you're like, well, this patient's fine. Their pH is 7.35. but then you look at your CO2 and your bicarb and they're abnormal. You're going to say to me, well, how the heck do I know which one it is? Your pH is closer to the acid side of things. So you know that this was initially a patient that had an acidosis. So now how do we know what type of disorder it is? Well, our CO2 here is elevated and our bicarb is also elevated. So again, if it was an acidosis, it would have to be a respiratory acidosis. And we know that because the CO2 is elevated, which is our respiratory acid. Our bicarb is elevated. If it was a metabolic alkalosis, our pH would be much higher than that. It would be closer to your 7.45 side, not the lower side. So that's how you'll know when it's compensated. So this is a compensated respiratory acidosis. And this would be considered fully compensated, and it's fully compensated because the pH is normal. Okay, so for your practice questions here, we're going to look at the first one. If you want to pause this, you can go ahead and answer them and then come back and listen to them. But we're looking at the first question, and this pH is 7.28, so we know that this patient has an acidosis. Our CO2 is low, and our bicarb is low. Our bicarb is very low, so we know here when you're looking at this, if the CO2 was low, we would have expected the pH, and if it was a respiratory issue, we would have expected the pH to be elevated because remember, our respiratory would be opposite. So since they're in the same direction, we can skip over the CO2 and look at the bicarb because our respiratory is not in the right direction. So with our pH being low and our bicarb being low, we know that this is a metabolic acidosis. And we know that it's partially compensated because our CO2 is also off. So this patient would be in a partially compensated metabolic acidosis. The respiratory system is kicking in to try to correct the imbalance. We then go to our next question where our pH is 7.51. So we know that this is an alkalosis. We then look at our CO2, which is actually normal. And then we look at our bicarb, which is 35, which is elevated. So here we automatically know it's not respiratory since our CO2 is normal. We know that this is a metabolic, it's an uncompensated, there's no compensation happening. It's a metabolic alkalosis. Our third question, our pH is 7.44. So again, that's normal. Our CO2 is 27 and our bicarb is 18. So we know that our CO2 is low and our pH is on the higher side of normal. So we probably had an alkalosis and our bicarb is low. So we know with that, if we have an alkalosis, our bicarb would have been elevated, and since it's low, we know that it's not a metabolic one. When we look at our CO2 is low. So we know that this is a patient who had originally had a respiratory alkalosis and the body kicked in with the bicarb. It lowered the bicarb to try to equalize this. So that's what brought the pH back down to 7.44. So it's back in a normal range. So this would be a fully compensated respiratory alkalosis. And it's fully compensated because our pH is normal. The final one we're looking at, our pH is 7.30. So we know that this patient is acidotic. We then look at our CO2, which is elevated, and we look at our bicarb, which is normal. So it's right on the outskirts of normal. So the patient's starting to try to kick in here. So we know with an elevated CO2 and a low pH that we have a respiratory acidosis. Here's another great YouTube video. So I hope you guys utilize the resources, and please reach out if you have any questions. I am going to post some ABG practice problems for you, and I will also go over those with audio if for some reason I'm not in class.